Hello and welcome. I'm Adele Gauthier, Research Manager at Breast Cancer Foundation NZ, and today we're talking about COVID-19 and breast cancer. If you've attended our webinars before, this one will feel a bit different. Each of the speakers is in a different location, so there's a higher than usual risk of technical problems, so please bear with us if that happens. And we're talking about a subject and situation that's changing constantly. So our webinar content is almost as new to us as it will be to you. So if this feels unrehearsed, there is a reason for that. We'll be keeping this informal without hopefully talking all at once. There is a little bit of housekeeping to do before we start. First up, you'll see there's a status bar or a task bar at the bottom of your screen. If you can't see it, you might have to move your cursor down. On that bar, you'll see a chat. Click on the icon to open the box, and there you can ask questions, which we'll get to later. You can also chat to other people during the webinar using that chat box, and don't worry about missing out on information while you're chatting. We are recording the webinar and it'll be available on our website tomorrow. You should be able to see the panelist who's speaking in small boxes on your screen. There are some size bars above that box where you can make that bigger. So today we're talking about COVID-19, which over just a few weeks has changed our lives in ways we never imagined at the start of the year. What we're going to talk about today is first up, how does having breast cancer and the treatment that you're having for it affect your risk of getting COVID-19? And then looking at the fact that we're living in this COVID-19 environment, how might that change your treatment in months? And then we'll get to what about if you're waiting for mammogram results or you're due for a mammogram, or what happens if you find a lump in your breast? Is that still the same as it was a few weeks ago? Now, let me just give a warning. We do not have all the answers here. The situation is changing by day and it will really vary around the country too. But what we're going to do is lay out for you some of the changes that are likely to happen so that you can kind of get your head around those and think about what you want to ask your medical team. Now, happily, we have a couple of speakers here who are experts and will be able to fill us in as far as we can on this changing situation. Dr. Monica Sani is a member of our Medical Advisory Committee, and she's also lead radiologist at Hutt Valley DHB in Wellington. And Nurse Natalie James is lead nurse here at Breast Cancer Foundation. So first up, I'm going to hand over to Natalie to talk about risk of COVID-19.
Thank you. So over the next few slides, I'm going to be briefly discussing the risk of getting COVID-19 and how our immune response works with viruses. So COVID-19 is a new virus and it spreads easily across populations. So it's expected that all people are susceptible to COVID-19, and that includes people with breast cancer. Our immune response is really our ability to respond and fight off infections like viruses, and to recover quickly should we get a virus. Things that can lower our immune response can include, of course, cancer and cancer treatments. But there are other things that also impact on our immune response that likely to be experienced across the population, but also by some people with breast cancer. And they include things like aging, other diseases like diabetes or heart disease, and some of the lifestyle behaviours that we have, and certainly smoking could be included in this. So when immunity is low, it means that once a person has a virus, they may experience more severe symptoms or complications like respiratory distress that we've seen associated with COVID-19. And of course, a person can be much slower to recover from viruses. And this is certainly the case when doctors and medical staff were able to review the case histories of people that had COVID-19 in China. So many of you will want to know which particular breast cancer treatments can be associated or likely to cause problems with our immune system. I think the easiest thing to say is I'll start with the least complicated. What we do know is that endocrine therapies like tamoxifen and letrozole or anastrozole, there's no evidence that these treatments affect our immune system. When we think of radiation therapy, it is possible for radiation therapy to impact a person's immune system, but this isn't likely to be the case for anybody who's had primary breast cancer radiation treatment. In terms of surgery, there's no specific data, but some people may have a lowered immune system during that time when they're recovering. And finally, probably the most complicated picture is chemotherapy. So we do know that chemotherapy and some of our new targeted therapies can be associated with a low immunity.
Natalie, if you're having trouble moving that slide, try clicking on it first.
That's okay. I'm just not having trouble changing the slide.
Yeah, just use your right arrow key to move on. See if that works. Maybe.
No, I don't seem to have control.
Okay, Julia, can you take that back?
Should I click the E?
No, I'll give that back to Julia. Here we go.
So an important question for anybody attending the webinar today is really going to be, if I have had cancer treatment or I've had an experience of breast cancer, how long is my immunity going to be impacted for? And I think the truth is that there's no easy answer for this. This depends very much on the individual, on the treatment that a person is having, and on the intensity of that treatment. But it's reasonable to say that while immunity might be suppressed during treatment, most people will start to recover their immune response in the weeks and months following treatment. And that the team, the health professionals looking after you, will usually monitor you for as long as your immunity is low. So you would expect that they're monitoring your blood count results and any other diagnostic tests to check that your immunity is recovering and you're recovering quickly from any infections you may have had during your time on chemotherapy treatment. It is true, though, I think, for most of us, that we would say that what can be slower to recover than blood counts and diagnostic tests is that feeling of kind of resilience, or that feeling that you're bouncing back from illness in the same way that you did before treatment. And I think that that's something that people will experience in a few months following chemotherapy, until they really do start to feel that they've recovered. So in these next few slides, I'm just going to speak a little bit about the changes that are likely to happen in cancer care during this very challenging time when COVID-10 is active in New Zealand. It's very clear that we want to all provide you with the absolute best of cancer treatment while keeping you safe from the risks of COVID-19, and that this is a balancing act across the hospitals and clinics that are responsible providing you with the opportunity for treatment. It's a balancing act for the health professionals and all the clinicians involved in your treatment. And we know that it's a balancing act for all of those people that are affected by breast cancer and their family. If you are planning treatment or receiving treatment, you can expect, though, during this time that your doctor is going to contact you to discuss care. They're going to be letting you know their recommendations on how we can work together to reduce risk of being infected with COVID-19 and support your immune system while giving you the best treatment available for cancer. They'll also talk about the overall hospital strategy and what will happen across hospitals should there be a situation where we feel that we're overwhelmed with cases, and how this might impact you. But please rest assured that they're going to continue to place as much emphasis on cancer treatment as they are on COVID-19. That they are going to take your choices and preferences into account, and that will continue to be an important part of any discussion. And you know, that treatment should continue. One of our clinicians has said, and this was a quote from one of our clinicians in the Auckland area, if you need to be seen, you will be seen, and we will make it as safe as possible.
Yeah, that seems like a good thing to aim for.
Mm-hmm. So what are some of the changes that we can expect? Well, it is likely that the appointments, particularly with your doctors and the medical team and some of our breast care nurses, are likely to occur over the phone or through video conferencing. It's also very likely that if there are times when your own doctors aren't available, that you may see doctors from another team. You'll know that they've been briefed about your situation, but it is important to know that there are times when you will be seeing other health practitioners. While it has always been important in cancer care to ensure that you and your family are welcome to come into our clinics to support you and to hear all that we have to say about cancer treatment, and that this is not going to be as possible during the COVID-19 situation, and you are asked only to take one support person into hospital with you. It's also likely that you'll be screened on many occasions during your COVID-19, during your hospital appointment. Now, this means at the front door, and when you come to the clinic, and maybe again when you're having your chemotherapy, someone's going to ask you about your symptoms and any risk that you've been in contact with people with COVID-19. Your clinic could be moved from to another site at the time at some stage during your treatment. And we've just said that there's a really important point that you should always ring ahead. The last thing I'd just like to mention is that there will be a really high emphasis placed on infection control, and one of those questions people will always have is, should I be wearing a mask? Rest assured, if you need to wear a mask, the hospital will talk to you about this. They'll supply the mask, and they'll talk about proper procedure when wearing a mask. One of the most important things to remember is trying not to touch your face, washing your hands frequently, and managing those infection risks. And we've just left an important watch point. Wait until you've been in contact with your health professionals. Don't show up at the hospital or a clinic without phoning first or making sure that you have an appointment.
Great, thank you so much, Natalie. We're now going to talk about changes in your treatment, and I'll hand over to Dr. Monica Sammy to talk about surgery changes.
Thanks, Adele. I appreciate it. So you're going to find that there are obviously going to be some changes of things that may have been previously scheduled, given what we're dealing with COVID. I want you to realize that there is an overarching plan to take care of you, and then that is not going to change. What may change is where the tests might be performed, some of the dates of surgery may change, and that is to make sure that we're not putting you at increased risk of COVID exposure, but that we're still here to primarily focus on making sure you get the treatment that you need. So as you see, there may be some changes for timing of surgery for some individuals. This will be based on looking at the type of cancer and deciding if it is an aggressive or urgent cancer, and if we can prioritize those into the areas where we still have theater time. There may be some delays for those that are considered less urgent cases, which means they may not be growing at a fast rate. They may not be extensive in stage. However, there's already protocols all of us are working on to see if there are other regimens we may be able to put in place instead of surgery. So you may be having discussions with your team about looking at hormone treatments, which are the endocrine treatments that were earlier mentioned by Natalie, versus chemotherapy treatments, so that we make sure we're doing everything we can, even during this uncertain time of addressing your cancer. So I want you to be assured that there is an overarching plan and that cancer is a priority and essential service, and that we're doing everything to make sure we get those services to you. As you might wonder, some patients will have a high risk of complication. Either they may be elderly or more at risk with COVID-19. So that's one of the reasons we might be looking at avoiding surgery or delaying surgery so that we're not increasing your risk. So treatment changes that you may have already heard about. In some regions, reconstruction surgery may not be available in the immediate future. This will vary region to region, depending on resources, depending on whether or not there's theater time. Your medical team will discuss those options with you and agree for the best treatment plan. It doesn't mean that option is off the table. It means that we need to make sure that when we go through these different regimens, we're not putting you at increased risk. So infection is always a risk that we weigh and measure before we go on with treatment.
We'll move on to changes for chemotherapy. So Natalie, perhaps you could cover those for us.
So as Monica said, there is a national strategy to make sure that everybody's getting the best treatment possible, and so there's a lot of thinking underpinning any changes that might occur in chemotherapy treatment. With the most important thing to remember is that your treating clinician is the person that's got the sign-off on your new treatment plan. But chemotherapy remains important for many people with breast cancer, and chemotherapy will be continued to be offered so long as it can be given safely. The safety levels will change as COVID-19 spreads, and so the risk of coming into hospital needs to be managed. So in practice, there could be a number of changes you may see develop over the next few weeks and may be discussed by the clinicians who are contacting you. It's possible that there could be a switch to lower risk chemotherapy, and that's because there are chemotherapies available that may have a similar outcome to the treatment you're on that will cause less of a challenge and less damage to your immune system. It may be possible also to give additional drugs to support your immune system's recovery during the time of chemotherapy. It is possible, again, that your clinicians will speak about switching to oral chemotherapy should it be available. The reason that oral chemotherapy has promise is that you do not need to attend hospital to take the treatment, and so by not attending hospital so frequently, the risk is less. Oral chemotherapy is, however, still chemotherapy, and you'll continue to be managed and monitored in the same way you would with any other chemotherapy regimen, including frequent blood tests. There is possible that there'll be changes in the timing of your chemotherapy treatment so that we can give you the best of treatment in amongst the competing demands across our hospital systems. And where your individual benefit of having chemotherapy is small, your doctors may also introduce a discussion about whether it's safe to continue to have the chemotherapy at all. One of the things that we'd like to really flag to you here is that if you are currently on chemotherapy, regardless of the situation with the COVID-19 virus, you must continue to follow the advice of your treatment team. And that advice is very clear that if you have a high temperature, a fever greater than 38 degrees Celsius, it is always an emergency and you should call your oncology clinic urgently. Follow the instructions that your treatment team have given you, even with this complication of COVID-19.
That's great. Thank you, Natalie. I'll just take a moment. Oh, sorry, Natalie, you finish that and I'll take a break.
Another example that we've popped up here, there are many treatments where people are required to go to either the hospital for additional supportive treatments or to their GP clinic, and sometimes even to district nursing clinics around the country. An example we've got here is the bisphosphonates, drugs like Xeloda or risitronate. During this time, there is likely to be changes with these treatments. So infusions given that are given every 6 months for 2 years to patients at risk of osteoporosis, people that are on having primary treatment or those that have metastatic treatment, should continue. Patients who have started their treatment, and haven't had dental work, who haven't started their treatment yet and also haven't had the dental work that's required to start treatment, may experience a delay while we are waiting for COVID-19 to be less of an issue in our hospitals. But and some patients may be transitioned to the alternative oral tablet. But what we do know is that different regions are going to have different options about receiving these supportive treatments in the community, and your team will be in touch to talk to you about them.
Great, thank you, Natalie. I just want to remind you all at home that there is the chat box where you can answer your questions, and we'll get to starting to answer questions in the next few minutes. So do go ahead and put those in now if you want. Okay, let's move on to I think radiation therapy. Monica.
Sorry for the delay there. So as you'll find, we were mentioning that there will be some changes in treatments. I want to assure you that while we're making some changes in treatments to help handle the amount of risk you have to coming into the clinic, either for radiation or chemotherapy, these changes are also based on evidence. So there are many trials going on around the world where they're looking at more condensed radiation treatments versus the usual 20 to 25, whether we can give those in 15 treatments and yet have good outcomes. And the reason we're prioritizing some of these now, as you can imagine, is to reduce your risk of exposure. So when you're coming in for your radiation therapy, we don't want to increase your risk of getting COVID-19. So you may see that your team is working with these different therapies around the world and different trials to see what would be suitable for you and your particular cancer. As you might see, ABC patients may receive a single higher dose for bone metastases. And then on the other end, there may be patients who are considered more low risk. For example, if you have low-grade DCIS, or you're considered an older patient with low-grade tumor. The benefit of radiation therapy is not excessively high. In some cases, the benefit may be low. So again, we would look at whether it's worthwhile for you to come to the clinic and have possible COVID-19 exposure versus waiting to have treatment or foregoing the radiation therapy at this time. That also, I can assure you, is based on trials going on in many different parts of the world where we're looking at low-grade DCIS in particular, if it's possible to have just surgery at some point or wait and watch. So again, we're using different evidence that we have to still be able to deliver treatment to you, but in a triage sort of way. So these are not shooting from the hip. These are based on different treatment strategies from around the world. And there may be a few weeks delay in start of treatment. Certainly your radiation oncologist will discuss any changes to your treatment plan with you.
Great. Natalie, did you want to comment on the general length number of treatments that patients do get in New Zealand at the moment?
In relation to radiotherapy, so many people will be on the 15 treatments already. Yeah.
Okay. So moving on from there, Natalie, we'll hand back to you.
Okay, so what can we do to reduce risk of COVID-19? I think the top line advice remains with the Ministry of Health and is the advice that's going out to the population generally, so all New Zealanders, which is that remembering things like self-isolation and following all the advice around self-isolation, washing hands, having a nominated person go out and do the grocery shopping for you, all those practical things that are well discussed discussed on the Ministry of Health advice site. The other things to remember are that if you can only take one person to an appointment, consider wisely who that might be. So consider options to, if your consultations are via phone or video, make sure that you plan ahead and ask, are there options for somebody else to sit in and hear and support you through that phone call or through that video consultation. Use of apps like Zoom or WhatsApp do have those opportunities for other support people in your family to join in and be part of those calls. I think it's also really important to remember that there's a lot of information happening, sometimes information that's different from your first impression of what your treatment plan was going to be, and it can be difficult to kind of retain everything and hear everything within context. So it's important after the consultation, ask your doctor for a written summary of what was talked about and an explanation of the decisions that you joined in to make during the treatment. And do see it as a joint consultation where your choices and preferences are as important in the discussion. Now I'm just struggling to change that slide, thank you. It's also important to keep abreast on the ministry site about other changes that are happening in our community. Know what's happening around GPs and chemists, so how's the best way for you to arrange to collect your scripts with the least risk of contact with other people that might have COVID-19 in the community. And the same with your GP. We know that GPs are doing most of their consultations online, and that's sensible, but should you require clinical examination and a face-to-face consultation, that may still be possible. It just requires a little bit more planning. And also, I think we've said it before, don't turn up at the hospital without an appointment, phone ahead first. And remember, your specialist has an overview of your entire treatment plan and is working to get the best results for you, so working together. And I think one thing that I would say here, you able to change the slide? The one thing just before Monica moves to the next topic is in terms of keeping yourself safe, we have provided advice that though as your family work to keep you safe as well, remember that flu shots for those that have had cancer treatment, particularly those recovering from chemotherapy or any other form of cancer treatment, and for the family are a really important way of managing risk during this time. Thanks.
Natalie, that's great. And I think one other point you mentioned when we were talking earlier, that if you are seeing anyone else in the health system, it's really important to tell them that you've had chemo or that you've got.
Yeah, it is. So I think being prepared to, you know, often, particularly in an urgent situation where you're perhaps expecting to see one person and you see someone different, or you're in a situation where you know the best and easiest way of getting urgent medical help is to call an ambulance or phone the health line or phone an urgent GP, then make sure that you're ready with information. In the first, in the short time that you're on the phone with someone, make sure that they know that you have cancer and that you've had chemotherapy or another cancer treatment, as well as, of course, the symptoms that you're ringing about that are concerning you.
Great, thank you. Thank you. And now we will move on. So perhaps not all of you watching currently have been diagnosed with breast cancer or have had treatment, but some of you might be waiting for mammogram results or have found a lump and be wondering what happens next. Monica, could you talk us through that, please?
Absolutely. So for those of you who have heard, BSA has put screening mammography on hold for the 4 weeks that we are in our current lockdown period. That means your appointment will be rescheduled. So it doesn't mean that these won't happen. Screening is really important to us, but right now we want to make sure that we're not giving you greater risk by bringing you into the clinic to COVID versus having a screening mammogram, especially when you're asymptomatic. Now, for those of you who had a mammogram and haven't had this,
that means that you don't have any, you don't have a lump or you don't have any symptoms.
That's correct. So that's what I mean by asymptomatic. which is a different category, and I'll get into the various different categories. So when we talk about screening, it means you have no symptoms or have not had previous breast cancer. That said, some of you have gone through screening and you're waiting for mammogram results and you haven't heard. I don't want you to panic. There will be delays as some of us are getting redeployed. We're still going through those screening exams and making sure the interpretations are still done in the same high quality way that we've always done. What you'll find though is as we're going through those screening exams, we are trying to prioritize those who will have recalls. We're actually going through the recalls to see if there's anything that has a higher degree of suspicion and making sure that we call those people in sooner. This will vary region to region, but we're doing it with the resources that we have, and we just don't want these results to just sit and wait or for you to wait. So we are going through plans of trying to sift through all the exams and making sure people who need to be seen sooner do get prioritized. Now, in contrast to screening, there are those of you who may be experiencing a lump or symptoms. And that process of what do I do in that situation doesn't change as it does even if we don't have COVID. So if you find a lump, the first thing you want to do is tell your GP. This likely may be a phone consultation. It's possible they may be doing an in-person consultation. And then the GP can refer you to your local breast clinic for further assessment. So what happens is then someone like myself will triage all of the requests, and we will look at what types of symptoms you're having, for how long, anything in your history that might point us to a certain direction, and we are triaging those so that we can bring those individuals where there may be a higher probability of cancer in first. But we are going through all of these patients over the period of time. We're just making sure that if there's a higher urgency, we try to make sure that we prioritize those patients so they're not waiting. One other thing I wanted to refer you to is sometimes it's very complex in trying to determine what is a lump. What am I feeling? Is this something concerning? My breasts feel very lumpy. I hear that quite frequently. If you go to the foundation website, we'll have these links added in for you as well. There's some really helpful resources of how to do a breast exam, the things to look for in just looking at the breasts, and things to feel for. But of course, when you're in doubt, which is completely understandable, you go to your GP, who can be another person who weighs in and says, yes, this is something that we should see you at the breast clinic, or this isn't something you need to be concerned about at this time. So that same system that you would do normally is still in place, and we are still seeing symptomatic patients. So while I mentioned earlier that BSA has put screening off, symptomatic clinics are still open. I just had my clinic today and we are seeing patients. We're just seeing them in a way that we can prioritize urgent cases.
That's great, Monica. Thank you. That makes a lot of sense. We're going to move on very shortly to questions in just a moment. I just want to tell you, first of all, about some of the Breast Cancer Foundation support services that are still running, although our nurses are working from home. So just to let you know, our nurse advice line, the 0800 number that's on your screen, is available, or you can email our nurses on the address given there. After this webinar, our nurses will be available on that line until 7 o'clock tonight if you have any questions. So do take advantage of that, or of course you can try them tomorrow. And when you leave the webinar, there will be a chance to say that you want a nurse to call you as well. So look out for that. We do have an online community, MyBC, where you can connect with other people who've been diagnosed with the same kind of breast cancer you have maybe in your area. That's a great way to connect with and find out what other people are experiencing at the moment. Download that from the app stores or go to mybc.care. Free counselling is still going at this point in time. The counsellors are working over the phone with patients and are very comfortable with doing that. So again, talk to our nurses or check out our website. And the physiotherapy services are also still available for people recovering from surgery. And I'm really intrigued to hear that physios are doing their consultations online and the phone, and apparently that's really effective. Natalie tells me that that's very popular. with patients. Okay, so we'll move on now to our Q&A. We have quite a few questions already sitting here, so we'll start working through those, but please do continue to add your questions. I'll just perhaps ask you ladies some of the questions here. So first up, one for, we've had a couple of people commenting about the number of support people allowed into consultations, and someone in a public hospital and someone in private have both said that they weren't allowed anyone to come in. So perhaps that's something we may have to brace ourselves for too. Natalie, do you think?
Yeah, so I think this is a real example there. The advice goes out nationally about the things that we can all do in our DHBs and in our private hospitals to manage risk. But in the end, the hospitals work together, just taking into account all those local things like proximity of one clinic to the next, number of people that can easily be fit into an area to modify that advice. You know, I do think that it's always optimal if you can take someone, particularly if you're having a long treatment like chemotherapy, to support you. But I guess it is likely that some hospitals and some services will ask you to come alone.
Right, yeah.
In that time, if you are feeling vulnerable or you do feel that you need additional support, I think that it would be reasonable to reach out to a nurse and just say that you do feel that you need someone with you.
Okay, that's good advice, thank you. And I think also this is a chance where we talked about getting WhatsApp or Zoom on your phone. You may be able to help bring your support people in by make sure your phone is charged when you go along, and maybe be prepared to bring someone in remotely. But you could also check in advance as necessary.
Yeah. And if no one can come, the nurses will take that extra care to spend time with you and to help you be reassured while you're there.
Yeah. We've got a question about scarring to the lungs from radiation therapy. A patient who has scarring to the lungs from radiation therapy but is not in active treatment at the moment, will there be an extra immune risk for that person? Monica?
That's a really good question. So yes, you bring up an excellent fact. So if you've had radiation therapy and there was known to be lung involvement, that may mean that it has reduced your lung capacity. Now, everyone's different, right? And so how much lung exposure there was for how much time is going to help determine if there's any reduced lung function. And the person who probably can best answer that for you would obviously be your radiation oncologist. If you're still visiting with your surgeon or having your checkups with your surgeon, that's an excellent question to have. Because that is an issue that needs to be addressed, but it will be different for each person depending on how much therapy you had. So it could be the number of treatments, but also how much lung was involved. So that's why it's hard to give you a specific answer, but I think it's worth it for you to have that conversation.
Great. And what about people with asthma after chemo and radiation? Are they additionally immunocompromised because of that? So
Natalie, did you want to answer that, or do you want me to answer?
So I don't. So there's a lot I don't know, but what I do think is that possibly it's not that it's going to change your immunity, but what it's going to change is your ability to manage the side effects of a virus like this. COVID-19 is associated with respiratory distress and a real challenge for our respiratory system. If there's pre-existing conditions or damage, it doesn't necessarily. It means that you might experience the symptoms more acutely, and you might be slower to heal or experience more complications.
So I think it's worth it to say, I mean, there's a lot of information we're still trying to understand, and the information, just understanding COVID itself, is constantly evolving. I find myself daily looking at medical journal articles to better understand how it's behaving, what the risks are just to the general public, and then obviously to a very particular patient population like yourself. So sometimes it's hard to give you concrete answers. I would say that certainly measures of caution. So everything that is being advised to the public applies to you. And obviously, if there's anything you can do to increase your protection, where that may be, you not doing the grocery shopping, but someone else, to limit your exposure, that's going to be key right now until we understand more.
Yeah, that's very helpful. Thank you, Monica. Natalie, some questions about immune effects of Herceptin. Does that lower your immunity?
Yes, I saw that pop across the screen, and again, this is going to be, I'll do my homework around this, and I encourage people to give us a ring over the next couple of hours and tomorrow about this. Herceptin does act on our immune system. It is also often given in association with other chemotherapy drugs. So in those settings, it's likely that there could be a lowering of the immune system, but remember that your doctors will be monitoring this through reviewing your white cell count and other blood tests during this time. However, if Herceptin is an important part of your treatment plan, expect that it will continue until you've had a discussion with your doctor.
And some people are on long-term Herceptin, of course, with ABC. So
Yeah.
And how about Zoladex or the zoledronic acid?
Yes, I saw that one flash up too. Again, I'm happy to do a little bit more inquiry into this, but I don't think that it would have such an impact on the immune system. We know that it's targeted to those osteoblasts and osteoclasts that line our bone, and so I'm not quite sure that I can see that it would have that impact. And it's not something that I've seen across clinical practice, but I will do my homework on that.
Great. Now, we've had questions about safety rules in the clinic. We did talk about it at the start of the webinar, which some of you may have missed. And we do know that some hospitals are making space between chemo chairs, for example, where possible. We had a question about private practice. We don't really know what those clinics are doing, but they will certainly answer the phone and tell you if you ask them. Would that be your advice, Nat?
Yeah, and I think that private clinics, particularly here in Auckland where I am, is a substantial amount of our oncology care is delivered in private clinics, and but it tends to be that the resources are shared across both public and private settings, and so there could be quite substantial changes in private clinics. I think that, and it will vary from region to region. So I think the most important thing is to ask your clinic what they're doing and what their plans for you are. I think that it's reasonable that most people will be making sure that there's a good distance between treatment bays so that people are protected from cough and droplet if someone does cough or something happens in the clinic area. So I think those normal precautions will be observed. We all know, those of us that are involved in chemotherapy in particular, that we often get very crowded in a small room trying to deliver a lot of treatment at one time. I think that's going to be less likely in these next few weeks when we've really got a lot of active COVID-19 in the New Zealand setting. I hope that answers.
That's great. Now, we've had a couple of questions about appointments for radiation therapy. People asking, is my appointment likely to go ahead? Some people waiting for appointments and haven't heard yet. Monica, in the public hospital, would you have a view as to what they should be doing to confirm those appointments?
So certainly, ring as you can. I know that sometimes is difficult right now because everyone is busy and trying to sort that out. I can tell you that there have been meetings, I know in the Wellington region where I am, of trying to sort out how to best prioritize patients. So we talked last week about patients who were currently undergoing treatment for chemotherapy and radiation, at least the chemotherapy patients who were in progress. The goal was to continue and not to stop, but to look at how to make the clinic more of a clean zone. So that's a lot of the reasons why your support person is not being allowed in, is we're trying to limit any potential COVID exposures. So they're trying to find ways to minimize risks, but still continue therapy. Now, this will, of course, differ from region to region. So it depends on resources. Someone asked about, private clinics how are they, you know, responding to the different treatment? I can tell you here, we are trying to space out patients. So there are not people sitting in the waiting room in our symptomatic clinics. So we're trying to give greater gaps so we have enough time to clean and air out the space and make sure that multiple people aren't sitting together. So we can try to, you know, honor that 2-meter distance, except obviously when your practitioner comes to examine you. And so each of us is trying to find, based on evidence, doing the best we can, but it will be a little bit different because resources will be different in different sites, space that's available, and honestly, you'll probably see it change every week because we're really getting the handle of this day by day. But I do suspect in another couple of weeks, we talked about whether or not we should have an update to this webinar because we'll have so much more information for you. And that will constantly change. So hopefully that puts some insight into that question.
Yes, yes, thank you. Natalie, there's a question about flu shots for carers of people with cancer. Do you have any insight into that?
Yeah, so I mean, flu shots can be a scarce resource, but what we would recommend is that those people that are the primary carer for someone with that's having particularly active cancer treatment or has cancer should have a flu shot.
Right, great. So they can tell their GP that.
They can tell their GP that. GPs will always balance the resource they have with when that's going to be available. So they'll give you a bit of a timing or a plan for timing of the flu shot. But we'd definitely recommend that people have them, and that includes those that are recovering from chemotherapy.
Excellent. Monica, a question for you. Here's someone who says her mum has a history of breast cancer and has found a new lump, has been referred to a private hospital, but the private hospital has said they're not doing any new mammograms or ultrasounds at this stage. What would be your advice as to what might happen next?
So that's a good question. Again, it depends on region. So if there is a public hospital near you or a DHB, as far as I understand, now again, variances against regions, we here in Wellington are doing symptomatic clinic. So you might investigate and see if it's possible to be seen by the public hospital if that is an option. And since we are seeing symptomatic patients, given your mother's history, we may be able to look at something of that sort and see if it can or cannot be prioritized against all the patients that are in the queue. But it's worth asking. I think that's maybe my big takeaway message for you all is ask. You know, there's no harm in asking the question, is something available to me? Is there anything else I can do? Always ask the question, because even if the answer is no, at least you ask, and you'd be surprised. Sometimes we do have information we can give you.
Great. And I certainly know that at Auckland Hospital and North Shore Hospital, they're also still seeing referrals from GPs. So definitely worth asking on that, whether the public hospital can come through for your mum. And that's something we might be able to talk to our nurses about later or tomorrow as well.
Absolutely.
Yeah. Now, a question from someone who said, if district nurses are too busy to flush PICC lines and take blood, is it possible for a patient to learn to do this? Natalie.
So this is going to be region to region. It's not unheard of that families and carers help to support intravenous access devices like PICC lines. The problem with a PICC is that it's in your own arm, and so it makes some of the technical skills required a bit difficult. My thought is that it's less likely. PICCs aren't in for a long time, and as I said, there's these technical difficulties. My thought is that it's less likely that a person will be asked to flush their own PICC. But what I would say is if you've got someone in the family that's perhaps a nurse and used to doing these things, again, like Monica said, speak up and offer their support. It may be that in this time of greater flexibility that can be used. But the other thing is that there is often within our international guidance around management of PICCs, there's a bit of variation in how often they need to be flushed. And so what we may find is that people are quite comfortable moving things to their outer limit. So trust that the team are doing the right thing and they'll prioritise getting the district nurse to the right place.
needs to be done. Great.
Yeah. So a few things in there, but hopefully that answered the question. Yeah.
That was very helpful, thank you. Now, a question about someone who says, my first day of chemo is tomorrow. I've been advised to have a flu shot. Is there a better time in the chemo cycle to get the flu shot? Is that something you know, Natalie? Or
So this is again something you can ask, because you're going to be seeing a number of health professionals tomorrow when you have your treatment. Your immunity is not challenged until about 5 to 7 days after your first chemotherapy dose. So there is perhaps an opportunity up front, or an opportunity that will arise again just towards the next time you're due to have your cycle of chemotherapy. So at the end of this cycle and before the next cycle. But check in with your doctor tomorrow, and I'm sure they'll give advice, but those two opportunities are best.
that's great. We have a query from someone who, with DCIS, who had queried the number of radiation oncology treatments they've been advised to have, which is up around the 25, I think. That might be something that one of the nurses could talk to this person about tomorrow, more specifically about that, whatever area they're in and so on, do you think? Or?
Yes, yeah.
I think I would just add that it's really hard because we're giving you sort of general advice and some information as we're receiving it. And each of you is going to have different disease. I think I saw a question of, what does it mean to, how do you decide if you have low-grade DCIS? And so that's something that when you have a needle biopsy is actually determined by the pathologist. There's 3 grades, low, medium, and high. But then there's also, we look at the size of the area involved and any other risk factors you might have. So that's why sometimes, we gave you some general ideas that we might cater treatment or tailor treatment slightly differently given the situation, but still feel that we have good success. But this will all vary on your disease, your health, and your body. So what works for one person may not be amenable. So if you've been told the 25 treatments is right, I think that you go with that. You can always ask questions as to how the 25 treatments helps improve your health status and curing that cancer. But all those things will vary from person to person. So just keep that in mind. These are sort of general overviews that we're trying to give you. But then hopefully you'll feel you can find your voice, or have that family member on WhatsApp or on Zoom ask for you, what does that mean for you? So speak up would be my best advice today, is speak up if you're unsure. You may feel that we are all busy and there's a lot going on, but you are still very important to us. So it's important as a patient that you find your voice or find the family member who can speak up on your behalf, and don't be afraid to ask. We will never feel put out because you're asking these questions. I'm always happy to take the time and recognize when you need more.
Great, thank you, Monica. That's really reassuring. I'll just pull up a couple of questions that were submitted ahead of the webinar, make sure we've covered those off. One from someone who said it's 2 years since her mastectomy and she's due for her annual checkup and MRI and so on. Should she postpone that? Or I guess more likely, will somebody else postpone that for her? Anyone have a view on that?
Yeah, I think, more than likely what'll happen, we have patients, we call them surveillance patients like yourself, who've had previous cancer, and then they come in for their mammogram or MRI or whatever has been recommended. So some regions, like the Wellington region, we have suspended that for the time being, knowing that it's a short period of time, and we intend to pick that up very quickly once screening reopens. But if you have an appointment, the best thing to do would be to call and ask and say, will I be able to come to this appointment? And they'll advise you. So if they say that they're still doing these appointments and they're able to do it in a way that they feel that the risk is minimized, then great. But again, that'll depend on your region. So call and ask.
Great. Now just to, we had a couple of questions from patients that the nurses are going back to directly. So if you haven't heard your question asked, that will be why. Rest assured that we will get to that. A couple more questions about immune compromise after lymph node removal. Is that something that affects immune systems, Natalie? Do you know?
So as I think as far as we know, the lymph nodes are an important part of the immune system, but having some lymph nodes removed isn't going to affect your overall immune response, except as Monica said earlier, with surgery, it may be a little bit impaired, just related to the time of the surgery, but not because of the lymph node removal.
Right.
Would you agree, Monica? Sorry.
Yeah, absolutely. Remember, you have lymph nodes all over your body. So the ones that may have been removed in the armpit or axilla area or in the breast are just a fraction of what you have everywhere else, internally and externally. So not just the ones you can feel, but there's many internally you can't feel. So they're there. So I completely agree with what Natalie said.
Great. Okay. And someone, this will come back a little bit to the surgical information we had earlier. I had a mastectomy within the last month, but no infection afterwards. Is my immune system likely to be lower than normal? Will that come down to that person's recovery time, I guess?
Yeah, so, most of surgeons, one of the things that surgeons will say is, after mastectomy, they will give you a recommendation when you can return back to work or normal activities. And oftentimes that's 3 to 4 weeks. And that's just an average I'm giving you based on the type of cancer, based on the type of surgery, where it was located, how everything went. So surgery itself doesn't necessarily lower your immune response. There's obviously healing time. There may be some pain or soreness that you have to sort with. And then, of course, the thing we haven't really had a chance to talk about is the emotional coping with all of this. It's a big thing to go through, changing, not just having cancer, but the change in your body and things that sort with that. And sometimes we need to really be able to sort through our feelings. And while none of those things necessarily take down your immune system, they certainly take some of your energy and your strength. So you have to be very mindful and kind to yourself during that time. Hopefully that gives you a little bit of information.
That is good. Thank you, Monica. We're nearly out of time, but just a quick question. Someone's worried, has concern for her sister who had breast cancer surgery and chemo some years ago, 2011, but she is a GP and very busy in this COVID-19 era. And her sister is worried about her being overworked, given her past cancer history. What support or advice might be available for people like her? This person asks. Natalie, do you?
Mm-hmm.
I was wondering if Monica
might
jump in on that one.
I'm happy to. So listen, when you think about, when we think about immune response many years out, it's not so much the immune response. Sometimes it's the pulmonary, that's meaning the lung capability after, depending on the type of chemotherapy they had. And so lung function, if you will. Usually many years out, the immune response is back to what it is for everyone in the average population, given that caveat, not knowing her disease or what, drug she was on. But hey, yes, her biggest risk right now probably is the stress from the work and that she's a healthcare worker. All of us healthcare professionals know that we are at risk, and we understand that, and we do the best we can to take care of ourselves. So supporting your sister, maybe giving her time to vent, to talk about it, or maybe having a chat about something completely unrelated to work. And if she wants to listen to you say, hey, is there any way for you to protect yourself and make sure you have some time for yourself at the end of the day? I'm sure those are all helpful things. And if she's able to take a walk with you, of course, 2 meters apart, all things that you can do to help decrease her stress. But, you're doing the best you can by caring for her and loving her.
That's great. Thank you so much, Monica. Thank you to both of you. Monica, as you say, medical professionals like yourself are at higher risk of this disease and just working like crazy through it. So I'd just like to express our gratitude, and I'm sure the gratitude of many people out there to you and your colleagues. We really do appreciate the care that you show to your patients through thick and thin, and we know that you're doing your best in incredibly challenging circumstances and doing a wonderful job. So thank you. And thank you, Natalie, who I know you've just spent your whole day talking with patients and helping out with our nurses dealing with inquiries. So for both of you to make this time available now, that's really fantastic. And thank you. to you both.
You're welcome.
So that's
So
it. Oh, thank you. That's it from us tonight. Do, as we said, give our nurses a call. As you leave the webinar, you will have the chance to fill in a very, very, very short survey to tell us what you thought of it. So if you could take a minute to do that, we would be grateful if you would. Otherwise, our nurses look forward to talking to you. We'll update this session if we've got new things to say in the next couple of weeks.
Absolutely.
And us tonight. Bye-bye.